We're now going to examine the hands and look at that examination again. Hello, I'm one of the candidates for the exam. Do you mind if I examine your hands and arms? Have you got anywhere tender or sore?
No.
Lovely. Could you start off for me by lifting your arms up and showing me your elbows? So I can look at the elbows cleanly. I can see there's no scars, no swellings, no lumps, no nodules, no bursitis. And bring your hands down for me and rest your hands onto the table. And again, no scars, no wasting of the thenar or hypothenar eminence visible, no scars over the wrist. Turn the hands down again. Normal contours to the forearm, no skin lesions, and no wasting to the interossei. Moving on to look at the fingernails, I can see no evidence of ridging, and ridging is normally best identified by feeling transversely across the nail, and there are no pits, no changes in colour, no abnormal cracks or splintering of the nails. Can I ask you to copy my movements? Place your arms so they're horizontal and put your hands like that. Now testing wrist extension, and you can see it's 90 degrees wrist extension both sides. Put your hands that way for me, please. And again, almost 90 degrees of wrist flexion. Can I ask you to put your elbows on the table for me, please? Turn your hands like that, and now move your hands towards each other. Thank you, so that's radial deviation. Turn your hands towards you, and now turn your hands towards each other again, and that's ulnar deviation. And the wrist classically has greater ulnar deviation than radial deviation. Place your elbows at the side for me, and I'd like you to grip a pen in each hand. And what I'd like you to do now is turn the pens so they're towards each other, but keeping your elbows at your side. I'm now testing pronation, and as you can see, it's 90 degrees of pronation, and turn away, and again, parallel to the floor. This is normal. Thank you. That concludes examination of the wrist. Moving on to examination of the hand. I'm going to ask you to lift your thumb off the table. I'm testing extensor pollicis longus. Keep it up, which not only extends but elevates the thumb from the table. Turn the hand over, and now I'd like you to touch the tip of my finger with your thumb. Touch my finger, touch flexion, touch my finger, extension, touch my finger, abduction, touch my finger, adduction, touch your thumb to your little finger, opposition. So we've tested all the movements of the thumb. Thank you, relax. And now we're going to move on and test the movements of the fingers. Lift this finger up, extensor indicis. Lift this finger up, extensor digiti minimi. Lift all these fingers up, extensor digitorum communis. So testing all of the extensors. Turning the hand over, bend this finger up, bend it here, and at the proximal interphalangeal joint is flexed, the distal interphalangeal joint is floppy, confirming that is flexor digitorum superficialis. Same again, that's FDS, same again, FDS, same again, FDS. Now I'm going to take the finger, I'm going to hold the finger straight and bend the tip of the finger down for me. Flexor digitorum profundus. The FDS is isolated by keeping the finger straight, so that movement has to be FDP. And I can repeat this at each of the digits. And you can in fact see, as we get to the ring and little finger, the adjacent fingers are trying to move as well. Thank you. Good. Can you put your hand like that for me? I'm now testing the lumbricals. The metacarpophalangeal joints are flexed to 90 degrees, and the interphalangeal joints are fully extended. This is the position that's held by the lumbricals. Hand down on the table for me. Spread your fingers out wide. I'm testing the interossei. Thank you. And now bring your fingers in close together. And I'm going to place a piece of paper between the interossei, the fingers, and get them to grip and hold on to them in turn. Relax. Next one. Relax. Next one. Relax. So I've tested the power of the dorsal and palmar interossei. Bring your hands back like this for me. Put them straight like that. And in a minute, I'm going to put a piece of paper between your thumbs, and I want you to grip it with your thumbs and stop me pulling it out. Okay. I'm now performing Frohman's test, confirming that the ulnar nerve is working to the adductor pollicis. Thank you. Relax. I'm now going to turn the hand over and I'm going to percuss over the carpal tunnel to Nell's sign if there was any evidence of any tingling or pins and needles in the hand. Anything happening?
Nothing at all.
I now flex the elbow up, identify the medial epicondyle, look for the groove where the ulnar nerve lies, and percuss over the ulnar nerve. Anything happening there?
Nothing at all.
Nothing at all. Thank you. Now I'd like you to place your hands up on the table like so and let your wrists drop. I'm going to gently hold them flexed. I'm now performing Phelan's test by compressing the carpal tunnel and looking for any changes in sensation happening in the hand. I would normally hold this position for 30 seconds. Anything happening within the hands?
No.
Negative. I don't expect to find any abnormal findings, so I'm not going to continue. And finally, I want to perform an Allen's test. I'm going to identify the ulnar pulse here and the radial pulse here. And then if you can make a fist for me, squeeze really hard. And I'm now going to compress both arteries. Relax your hand. You can see the blood's been squeezed out the hand. And when I release the ulnar artery, the hand pings up very quickly within a few seconds and returns to normal. That confirms the ulnar collateral supply is intact. Squeeze the fist again, really hard. Now relax your hand. And now I'm going to release the radial artery. And you can see the hand's pinking up, but slightly slower. And that's normal because the ulnar artery is normally the dominant arterial supply to the hand. It's always important before performing a blood gas or a arterial line to do an Allen's test to confirm that there is a collateral circulation to the hand. Finally, to complete the examination, I would test sensation, and I can grossly test sensation by getting the patient to close their eyes and comparing both sides. Does that feel the same?
Yeah.
Does that feel the same?
Yeah.
Does that feel the same?
Mm-hmm.
Does that feel the same?
Yeah.
Turn the hands over. Does that feel the same?
Yeah.
Does that feel the same?
Yeah.
And that.
Mm-hmm.
If I wanted to test sensation more formally, there are two other tests that I can do. One of the most useful tests for sensation in the fingers is the Bic Biro test, and this relies on the fact that in a finger where the nerve is damaged, you will lose sweating. In a normal finger, if I draw the biro across, you can see it sticks to the sweat. In a finger with denervation, there will be no sweat and the biro will slide across more freely. The second test that I can do is to perform a test for two-point discrimination. This requires taking a paper clip and then finding an area of the finger on the normal side and testing the minimum distance at which the patient can reliably tell the difference between 1 or 2 points, then measuring that distance with a ruler, and then repeating on the other side to see if there is a difference. And if the two-point discrimination is the same both sides, it makes a nerve injury very unlikely. So just as an example, close your eyes for me, please. Can you tell me whether that's 1 or 2 touching your finger? 1 or 2? 1 or 2?
2.
1 or 2?
1.
1 or 2?
2.
1 or 2?
1.
1 or 2?
2.
1 or 2?
1.
And 1 or 2?
2.
So the patient was reliably picking up most of those correctly, so I can now measure that distance that would tell me the two-point discrimination for this particular segment of the finger, and I would then repeat this on the injured side. To complete my examination, I would want to examine the neck and the shoulder, and I would also wish to proceed to more formal testing using a whisker for light touch as well.